the treatment, we have different options. The surgery is limited by the high risk. So when a surgeon see a patient with a high risk, they will not go in to touch the patient, especially if you have isolated tricuspid regurgitation. You have only the tricuspid. Nobody wants to go and open the chest. You have for this patient the medical treatment. Medical treatment is diuretics, but most of the time this is not efficient, or if it's efficient, it's limited. And you have a new emerging treatment, the transcatheter devices that are not necessarily approved in the US for now. Some of them, they are approved in Europe. When you look at the American guidelines here for the treatment of, if you look at the indication of the class 1 indication of the tricuspid valve repair or replacement, and you can see that the only class 1 indication that means you have to do it is, regardless of the symptoms, when you have severe TR, the same, when you are doing the surgery, you can do it at the same time of left-sided surgery. Left-sided surgery. That means at the same time of left-sided surgery. So if you are not repairing something with the left side, like aortic valve, mitral valve, most of the time is you do the mitral valve surgery, you do the tricuspid with it, even with less dilated tricuspid annulus. If you have still dilated tricuspid annulus but not severe TR, many surgeons do the repair to prevent the progression of the tricuspid regurgitation. But the only indication is when you have surgery. So if you have a patient already operated many years ago and they come back for recurrent regurgitation, you cannot, there is no indication to go and touch the patient. So what happened is most of the patients remained untreated. This is because of the high mortality. And this is why the transcatheter techniques, I think one of people who think that will take over, and in a couple of years, maybe 5-10 years, will probably the repair of tricuspid regurgitation will be the same as TAVI right now. And for TAVI, we had the valves. We don't have the repair like we have for tricuspid. For tricuspid, there is multiple devices that can be used. I know there is challenges for this valve because it's a large valve, 10-12 square centimeter for the annulus, around 9 square centimeter for the valve area. So this is a very large valve, but still we can do repair in many cases. This is the landscape of the tricuspid area right now with the different devices. You have here some technical, some surgical techniques, and the transcatheter repairs. Transcatheter repair will try to mimic these surgical repairs. So it can be application of the annulus to exclude the posterior leaflet and leave 2 leaflets here. It can be an annular repair with the annular device or without the annular device, and you have other techniques as well. Some of the devices are intended to go to the annulus, some of them to the leaflets, and some of them we call them heterotopic replacement. So they can put a valve in the vena cava or somewhere else to prevent the reflux and the hepatic congestion, but these are experimental. The most promising 3 devices that I will present to you with some examples is the annular device that we named the Cardioband from Edwards, the Triclip from Abbott, and PASCAL repair system from Edwards. And these 3 devices already got the CE mark, so they can be used in Europe, but they are still under investigation in the United States. So one of the earliest studies showing benefit to treat with the transcatheter devices for the tricuspid is the TriValve registry. And this registry included more than 500 patients that were divided. It's not randomized, but they were matched in 2 groups, similar groups. So 268 in each group. One of them treated with the devices, the other one is a control group. These patients were overall high risk, 76 years old, and oral score 9%. So this is a high risk population. Different devices were used in this registry, not only one type of devices, but could be Cardioband or Triclip. And this study showed here on the left side, the patients who were treated with the blue line, those who were treated with any type of the device for the tricuspid regurgitation had much better and significantly better survival without heart failure. And on the right side, we can see that also treatment resulted in decrease in mortality. So there is better survival in the group of patients who were treated with the device compared to the ones who were not treated with the device. That were only medical treatment, likely diuretics in addition to other heart failure treatment. So this is a registry that we have now randomized, prospective or randomized studies. So this is one of the earliest also prospective studies with the Cardioband system. The Cardioband is a band, c'est un anneau, c'est un semi-anneau. Donc we have, this is before the implantation, and on the right side after the implantation. So you have a band with many anchors. I don't know if you see very well here. Vous avez une espèce de ressort de clou qu'on va implanter dans le myocarde. Remember, there is no separate tricuspid annular device, but we implant them at the junction between the leaflet and the myocardium. But basically, we implant them in the myocardium. So if you get a troponin after the procedure, troponin likely will be high. You start close to the aorta, but not too close to the aorta, because you have close to the aorta, you have the conduction system. So you have the AV node. If you put your anchor here, you will create conduction disturbance, and the patient can get a pacemaker that can be a problem for the leaflet themselves after the procedure. So you start, there is no defined strategy, but yeah, like you have to leave a reasonable distance between the aorta and the first anchor. And then you progress posteriorly until you arrive close to the coronary sinus. And after the anchors are implanted, you can contract your band device and you close the gap as much as you can. Of course, there is a maximum for contraction. You cannot reduce a huge tricuspid annulus to nothing. But there is some indication for the size. There is a different size of the device according to the tricuspid annulus. But if you have a very large annulus, likely more than 55 millimeters, you cannot implant the device for now. There is now such a large device available at this time. And then you get reduction of tricuspid regurgitation. Before to do it, two main things need to be done. The assessment of the tricuspid annulus, and this is kind of answer to the question asked before. You have to look at the tricuspid annulus from different plane, like the valve. This is the septolateral. This is the anterior-posterior dimension, and you see this is a oval shape, and you can get your dimensions, your area, and your circumference, and this gives you an idea about the device size. But the most importantly, the CT scan will be the determinator of the device choice, because we can assess the circumference and the dimension of the tricuspid annulus, and also the proximity of the right coronary artery. I don't have an example here with injection to show the proximity with the coronary artery, but this is two main things to consider in addition to the other parameters we've seen before. If you are done with your dimensions and proximity of the right coronary artery, as an indication, if you have a distance between the right coronary artery and the annulus less than 4 millimeters, this is a high risk patient for this type of intervention. You can injure the right coronary artery, so you better excluding this patient from implanting this type of the device in this case. This is a case of a patient with the severe tricuspid regurgitation, as you can see here, with a pacemaker. And from this key view, we have seen before the in-face view, or transgastric view obtained here at 40 degrees. Usually we can obtain it from 0 to 30 degrees. from the transgastric. We can see the septal leaflet, the posterior leaflet, the anterior leaflet, and the pacemaker lead is free. There is no interaction with the leaflet, but it is within the jet area. So the question was, will this patient benefit from cardioband treatment or not? And such we are learning from this field. There is no such guidelines, so we decided to include this patient in the study. And this is here one of the anchors delivery. So this is, as you can see here, this is anchor number 6. So they started close to the aorta and they moving around. So they arrived here to anchor number 6, and you can control with the biplane mode here, the X plane on the machine. You can get the other view on the other side. The implantation of the anchor should be done just close to the insertion of the tricuspid leaflet, not too far away, and not on the leaflet itself, because you can injure the leaflet and cause primary TR instead of having a secondary TR in this case. And this is another anchor here. I want you just to notice the movement here. We have the catheter, and you have this pushing. The operator is pushing the anchor into the myocardium, so the band can be stabilized. At the end of the procedure, this is pre-procedure, before to start the procedure, and this is at the end. You see here part of the band here. The band is contracted, tricuspid annulus gets smaller, and the regurgitation is really traced to mild here. This is an excellent result for this procedure. This is wonderful. At 6 months, you can see here that you have the result is maintained at 6 months with the trace tricuspid regurgitation. I mean, this is a challenging procedure, but still, if we select the patient well and you have a good operator, you can get a nice result. These are the 6 months for this technique from the first study, the TriRepair study. That was we were the core lab for this study for the analysis, but the implanters were located in Europe, most of them in Germany. And this is these are the characteristics of patient. This is old patient, 75 years old average, most of them female, 73%. The OR score was is quite high, 4% for mortality, but this can be underestimated because these are frail patients, so we can underestimate the comorbidities. You have a lot of comorbidities. You see here 80% of hypertension. You have diabetes, dyslipidemia, COPD, heart failure. So this is quite a frail population. And these are some indication of the procedure. You can see that the procedure time is almost 260 minutes, which is around 4 hours. This is quite long for a transcatheter repair, and sometimes is frustrating. But as the operator got familiar with the technique, the time got lower. This is one of the longest procedures so far for the transcatheter repair. And I want also to look at this, the complication here. There were two deaths, most likely due to coronary complication. There were 3 coronary complications. One of them is anchor penetration into the right coronary artery, and this is because the proximity or the trajectory during implantation. There was one occlusion of a side branch of the right coronary artery, and we said before the proximity between the right coronary artery and the annulus become close, small. In the mid portion and the distal portion, and this is the result of that. And there was an aggravation of pre-existing stenosis at the distal branch of the right coronary artery. When there is no injury and there is stenosis, this is most likely a reaction to the edema or the perilegional trauma that will regress within hours to days. We have seen many cases that regressed spontaneously without any treatment. You can see here the clinical and echocardiographic data. There was a clinical improvement in NIHAC classification. Most of the patients were class 2 or 3 before the intervention. At the end of the intervention, nearly 90% of them were class 1 or 2. There was an improvement in 6-minute walking distance, and also there was an improvement in the severity of peripheral edema. And this is for the patient, it's something, because when they have a lot of edema, they can't breathe. They are just sitting. When they are improved, they can come back to life and appreciate their life. So it's helped the patient to improve their symptoms and their quality of life. And also we can see from echo quantification, the PISA went from almost 0.8 square centimeter, which is extremely severe, to around 0.4 in average. Yet many of them were in the moderate or mild grade. Some of them stayed severe because they started from very, very severe. So you may have improvement within the severe range. If you go from 0.8 to 0.5 or 0.4, this will help the patient anyway. This is not optimal, of course. This is the beginning of this field. There is other studies, similar study to this study, which is the Cardioband US. We finished the enrollment for this early feasibility study, and we are having some nice data under review for publication. I can tell you that the results are similar to the European study, and we have probably will have another randomized study in the future. So that was for the Cardioband, the annular device. Now, one of the most interesting devices is the TriClip, or the MitraClip. Is a small iteration of the MitraClip. We did this work we started doing 2 years ago, and we published this work in Lancet in 2019. So that was the first prospective study with the TriClip device in the US and Europe. This is the structure and the aspect of the device. You have the clip at the end. You have this is the delivery system and a steerable sleeve here, so you can manipulate the device easily under echo guidance, of course. This is the device, how it looks like from close. You have the two arms of the device. There is different size, many generation now. The one that was used in this study is the one of the first generation, so one of the smallest. In the next and the other studies, we are using larger devices. Even with this, the results were very interesting and were accepted in a high impact journal. On the right side, you have a patient with severe tricuspid regurgitation treated with the TriClip device, or MitraClip, and the result is a TriSTR at the end. So this is an excellent result. This is I will go briefly over the study design. This is, as said, prospective study, and the goal was to assess the safety and efficacy of this device in patients with moderate or severe tricuspid regurgitation. Both functional and primary TR were included. We excluded patients who have severe pulmonary hypertension because we thought this is not good for this patient. The primary determinator for prognosis is the pulmonary hypertension, and we excluded patients with severe left ventricular ejection fraction less than 20%. Similar to the previous study, old patients, 78 years old in average, most of them female, and most of them with hypertension and atrial fibrillation, around 90% with atrial fibrillation and hypertension. So, and many comorbidities that you can see here, renal disease, 46%, among other comorbidities. The device was implanted successfully in 100% of patients, and we got a significant reduction in tricuspid regurgitation following the implantation is in nearly 90% of cases after the procedure. The time of the procedure is 150 minutes, which is much lower than the annular device. And the device time, when you start touching the device to the end of a procedure, is 75 minutes, 1 hour and 15 minutes, which is reasonable and can be lower if you have an easy case, or you have a very well-trained operator. 185 clips were implanted, in overall 2 clips per patient. Most of the clips were implanted between the anterior and the septal commissure. This is the most solid site for the implantation. Some of them, 20% were toward the posterior and septal commissure, and only a minority were between the posterior and anterior leaflet. And the studies have shown that if you have an implantation between the posterior and the anterior leaflet, this is not a solid site, and the device can detach, or repair cannot be successful. There was, compared to the other device, there was 0 death at 1 month. Compared to the surgery, where we have 10% approximately of 30-day mortality, with the edge-to-edge repair, there were 0% mortality at 30 days. So that was the surprise for everyone, and was one of the best results obtained so far. There were, of course, some complications during the follow-up. There were 6 major adverse events at 6 months, which represent 3.7%, which is still at 6 months lower than the mortality at 30 days for the surgery or other techniques. So this is very acceptable for percutaneous repair. There were, similarly to the previous study, an improvement in tricuspid regurgitation severity. Most of them were, decreased, and we noticed reduction by 1 grade, at least 1 grade, in nearly 90% of cases. There was an improvement in RV remodeling. So the objective, one of the objectives of the repair, is to give time to the ventricle to remodel and to get smaller and to recover the function, and this was the case here. There was positive remodeling here, and there was trend toward improvement in systolic function that was seen more at 1 year, but I'm presenting here the 6-month data. Improvement in NIHA class symptoms. So there is also improvement in quality of life as measured by KCCQ. This is one of the methods to assess the quality of life we use. And there was an improvement in a 6-minute walking distance by 55 meters in average, which can be very helpful for this patient who spend most of the time at the hospital or sitting home. They can walk and they can change their life. The 1-year data were presented at oral PCR in 2019. The results are similar, but as I said, some of the patients decreased the TR during follow-up. Majority of them, 64%, were mild or moderate at 1 year, and there was improvement in RV function at 1 year. We have more studies coming with this type of the device. We have the Triluminate pivotal trial, which is a randomized study, and up to 700 patients are expected to be enrolled, and the study is enrolling, started this year. So we'll have some nice data to expect from this study. Another very interesting device and different device, this is from Edwards. This is the competitor of the MitraClip. You have here, we call this the PASCAL repair system. It was first used for the mitral, but now is being tested for the tricuspid. You have 2 pedals instead of arms. We call them pedals, and this is a central spacer. And the pedals can open independently, so it's very important. So you can capture 1 leaflet at a time and then capture the other leaflet. This is very interesting when you're doing this type of repair. This is the device when it's open, and this is when it's closed. The leaflet, different than the MitraClip, the leaflet get between the paddles and the spacer. The leaflet go here. So it's less traumatic. We think it's less traumatic than the mitral clip, because the mitral clip will take the leaflet between the two arms. It can damage the leaflet, and this is we think this is less traumatic for the leaflet with this device. We have a case here of a patient with severe tricuspid regurgitation. The jet is located close to the aorta here, you see. So this is the anterior septal commissurer, and this patient was accepted as a candidate for repair with the PASCAL device. We see here the operator entering from the inferior vena cava and arriving to the right atrium. We try to do a rotation toward the tricuspid valve in the bicaval view here on the left side. We try to do angulation orientation toward the left, and this is we start here from the mid-esophageal and we come to the modified view to go to the leaflet, and we can see here from the biplane mode a longitudinal view with the septal leaflet and the anterior leaflet, and this is very important to control the progression of the device across the tricuspid valve. We have here the operator crossed the tricuspid valve with the system, and there is a grasping or clasping of the leaflets here with immediate reduction of tricuspid regurgitation. Of course, sometimes it takes time to catch the leaflets. And this is the final result, which is very amazing, only mild tricuspid regurgitation. And of course, it's very important when you do edge-to-edge repair with any type of edge device to control the mean gradient, because sometimes you can induce stenosis. It is very rare for the tricuspid because it's a large valve. If you start from 9 or 8 centimeters square for the tricuspid, it's unlikely to get stenosis unless you implant 3 or 4 devices, as we have seen in some of the cases. We have the couple of studies. We finished the enrollment for the PASCAL EFS study. The 1-month results are under review, and 6-12-month follow-up is in progress. We have also the PASCAL Pivotal 2 study, which is a randomized study with a single arm in addition to the randomized arm. More than 800 patients are expected to be enrolled in more than 60 sites, and the study is enrolling. So last, we will finish with this slide, with this 1 or 2 slides. We have the transcatheter tricuspid valve replacement, which is another option, and probably that will become one of the primary options in these patients, especially when the repair is not possible. We have different kind of valves. We have the Navigate. This is a large valve. You can see up to 54 millimeter size available. When you compare to the TAVR valves, this is a very big valve. You have the tricuspid valving valve or valve in ring that can be performed using Sapien 3 or other valves, and that give you here a nice view of how the tricuspid valve is oriented. When you look at it by echocardiography, it's facing you, looking at you. And we have here the Evoke valve that was used for the mitral first, and now is being investigated for the tricuspid. Both the Navigate and the Evoke, they have kind of winglet to stabilize the valve, to catch the leaflet, and to stabilize with to hold on the tricuspid annulus or the tricuspid leaflets. All these are experimental valves, of course, but the results, the main advantage of using a valve is to eliminate the tricuspid regurgitation completely. So you get 0 regurgitation. Sometimes it's problematic when you have regurgitation. You close the regurgitation and you have the RV is really suffering especially if you have pulmonary hypertension. And the inconvenient is this patient will need anticoagulation because especially valve on the right side, it's a low pressure system, so you will have thrombosis if you don't give anticoagulation. The thing to consider here is that most of the patients included in these type of trials and having tricuspid regurgitation have atrial fibrillation. So probably most of them, they are already under anticoagulation. And if this is the case, then it's not a big problem. But otherwise, this is one of the limitations. So I want to conclude by saying that the tricuspid valve is gaining a lot of interest and is no longer the forgotten valve. And understanding tricuspid valve anatomy and tricuspid valve pathophysiology is crucial. Is crucial in the area of transcatheter devices. These transcatheter devices are going to be probably one of the best options for these patients. And the transcatheter devices need a good imaging with the transcatheter, with the transesophageal echocardiography, both two-dimensional and three-dimensional. And we have a nice and promising results from early studies, and we are waiting for large randomized trials to validate these results and to provide outcome data. And with this, I will thank you. I will conclude by saying thank you so much for your listening. And if you have any question, I try to answer.
Thank you, Dr. Abdelaziz, for your excellent presentation.
Thank you so much.
And your great expertise. Donc, il se fait un peu tard. Je pense vraiment qu'il nous faudrait encore une autre session. Pour qu'on organise, parce qu'il y a beaucoup de questions d'abord. Il y a beaucoup de questions. Et on veut savoir aussi ce qui se passe dans le VD, dans le ventricule droit.
Ouais.
Donc, je pense que et vous avez une très grande expertise dans le domaine, une très grande expérience. Et on vous remercie de partager cette expérience avec nos jeunes qui sont assoiffés de savoir. Parce que malheureusement, il se fait un peu tard. On va laisser peut-être les questions pour une autre fois. Donc, barakallahu fik ala kulli hal fi ilmika, barakallahu fi ilmika.
Allah barik fik, merci beaucoup, c'était un plaisir d'être avec vous.
وفي مالك ربي يجازيك.
الله يسلمك.
نحن أعداء. On laisse là le mot de la fin aux invités. Aujourd'hui, bon, vous êtes notre principal invité, bien sûr, mais nous avons les blidéas qui sont avec nous. Donc, je ne sais pas si, je pense pas que M. Bouafia soit là, soit Bourgda, soit Nedjar. Est-ce que Nedjar est là? Je ne sais pas.
Nedjar, je suis toujours là. J'étais scotché à mon écran.
Donc, on te laisse la conclusion, de cette excellente conférence de notre ami DAHOU Abdelaziz. Et j'espère qu'il va participer avec nous à monter et nous trouver d'autres Algériens. Inch'Allah.
Inch'Allah.
C'est gentil. Au nom de notre service de Blida, bien sûr, je remercie d'abord le service de notre professeur Ben Khadda de cette invitation. On remercie bien sûr Dr DAHOU pour cet excellent exposé, vraiment approfondi, exhaustif. C'est vraiment extrêmement intéressant. Je suppose déjà la première partie, notre équipe du laboratoire d'échocardiographie, ils ont vraiment apprécié. On en parlera demain dans le service, ça c'est clair. Les différentes méthodes thérapeutiques, pareil. Il y a pas mal de questions également qui restent en suspens. Je suppose, Inch'Allah, je l'espère, qu'on les abordera la prochaine fois, comme dit le professeur Ben Khadda, surtout le ventricule droit. Sur le ventricule droit, ce serait extrêmement intéressant de compléter cette session par le ventricule droit. Voilà, donc on vous remercie énormément pour ça. Au nom de notre service, merci encore. Nous étions vraiment scotchés à l'écran, vraiment scotchés pour suivre toute cet exposé. Vraiment, barakallahu fikum. C'est extrêmement gentil et j'espère vraiment à très bientôt pour d'autres exposés.